Jawohl, sehr gut. Fräulein Fenton. Good morning. Hello. I hate interrupting you. I know you're having a good time. Welcome back. Welcome to day 2. Did y'all enjoy day 1? Okay, those of you that are not clapping, or I know you're still sleeping, caffeine hasn't started moving yet. So we have another jam-packed plenary session for you this morning. But before we jump into that, I want to remind you about your vendor card, that you need to get it stamped by the vendors and then turn it in to the registration desk by 5 o'clock. And then we'll be picking the winner tomorrow. And for those of you that weren't with us yesterday, the winner will be announced. You need to be present to win tomorrow, though. And you'll have a free registration for our conference next year in Long Beach. So just remind you about that. And then I also do want to, as we're talking about folks that have sponsored our conference, I do just want to highlight, since we have our partners here with Public Health, they've been a really big part of our conference as well, and they have been sponsoring your Wi-Fi, so just want to thank them for that, because we all do want to stay connected as we're away from the office. So yes, thank you so much, Department of Public Health. And so speaking of the Department of Public Health, they are here with us this morning in full force. We are so fortunate to have their director, Dr. Karen Smith, and she's going to be speaking with you this morning. So Dr. Smith, she has been with the Public Health Department since 2015. Prior to that, she was in the field working with the Napa County Health and Human Services. She's a nurse, but she is far and above, beyond all that. She's an incredible person. And in speaking with my director, she says she's really good people. And I think that just really describes her the best. So just want to turn this over to Dr. Smith.
Good morning. Just to be clear, I am a doctor, not a nurse, so don't ask me to do anything important or be compassionate, because that isn't what we do. And also, I actually know the tiniest bit about substance use and abuse in California, because in my 10 years as health officer in Napa County, I was also the medical director of the substance use program there. So I got to know both drug Medi-Cal, I'm sure everybody's favorite topic, but also, and most importantly, I got to know the counselors and other staff who have devoted their lives to combating substance use and abuse in California, and that was an incredibly wonderful and educational experience for me. Now, there's nothing obviously about how to move the slides. This does not, oh, there it is, never mind. Okay, nor do I know how to work technology. So I'm going to actually talk from a slightly different perspective than what most of you probably are used to. I'm not going to talk clinical. I'm primarily going to talk the public health perspective on how we are looking at the opioid crisis in California. And because we're all in this together to reduce the use of opioids, the overuse of opioids, and the deaths that have come about because of that. And so I know most people, when you think of an outbreak, you don't think of something like opioids or an epidemic. People call this an epidemic, but it really is an epidemic. It had a start, it has causal factors, there are things that actually protect it. And like a couple of other epidemics, unlike most, the healthcare system itself has increased the spread of this particular epidemic of opioids. Same thing was true with Ebola, actually. The first Ebola outbreak occurred almost exclusively in the healthcare system in Africa, where they were sharing needles because they didn't have any others. But from our perspective, public health approaches this slightly differently, but in an incredibly complementary way. Most importantly, our way of doing business is not transactional. It's not typically person-to-person services, but rather it's bringing together entire groups of people, multi-sector collaboratives, to work together to approach issues from a variety of perspectives. And most importantly, our focus is always, always, always on prevention. And that's prevention right up front, but also prevention way upstream in terms of what is it that actually initially causes these issues. I also want to make a point that we are very, very well aware that the opioid crisis is not an isolated problem, and that we have basically an addiction crisis in America. We seem to have a new drug every sort of 10 years or so. But the fundamental problem is one of addiction and a society that somehow or other propagates that and doesn't put enough services into and enough attention on how do we keep this from happening again. And also, very importantly, almost nobody who has a substance use disorder uses a single drug. And that's true for opioids as well. Polysubstance use is the norm, not the exception. That said, I am going to focus on opioids because that's why we're here today. Now, I have a suspicion that not all of you are data geeks. So I am going to show you some data, but it's largely pictures, graphs, which I love, and I'm going to go very quickly through the data. So for those of you who are data geeks, though, and if you want to have information about what's going on in your county, and even in some of the city areas, the sub-county data, we have an interactive opioid dashboard. Actually, on the front, inside the front cover of your program is a snapshot from the dashboard. You can go in there and really drill down both on what you're looking at. Is it deaths? Is it prescriptions? Is it, whatever other issue by population group and geographic area? And it's very easy and pretty intuitive to use. There's some help on there on how to do it. But using the dashboard, this is what a piece of the front page looks like. Just to give you a sense overall of the magnitude of the issue in California, we had in 2017 just 1,800 opioid deaths. Now, if you look, so 1,800 deaths, but we also had 8,000 approximately emergency department visits and hospitalizations. That's a lot of people. And 22 million prescriptions for opioids were written. Now, I also need to say that there are legitimate uses for opioid drugs. There really are. And that's one of the challenges. This isn't heroin, where you can basically say everybody who's using heroin probably has a problem that should be dealt with. There are people who really do need these drugs. So one of the subtleties about this particular issue is trying to provide that nuance. 2017, our 2017 death data, that 1,800, is actually preliminary and probably undercounts, because it takes a full year to get all of the deaths registered and fully sorted for a given year. So there are actually probably more than that. Now, these are lower than these rates of death and overdose and hospitalizations are actually lower than the national average. But in California, this is as elsewhere, this is a very not homogeneous epidemic. So it is affecting different parts of the state very differently. And we have counties where the numbers and the rates are as high as the worst affected states in the United States. And I'm going to show you that. Oops. This is a graph also from the website that shows you, it's sort of a heat map of counties by county of rates. And this particular one is all opioid overdoses. That means prescription, heroin, fentanyl, et cetera. And you can see that there are specific counties that have much higher rates than the state overall. And so it's very important that we look at this outbreak based on where it's happening and design our interventions to work in those places, even though the northern rural counties, which are most effective, have far fewer people. So there are far fewer cases, but they have the highest rates. So if you're LA County, you're going to have a massive number of actual people affected, but fewer per population. And so it really is important that we focus. Modoc County, for example, the age-adjusted death rate for Modoc County is almost 24 people per 100,000, as opposed to the overall state rate, which is much, much lower than that. And Humboldt County, 21 deaths per 100,000. Those are very high death rates. So, oops, I keep looking up there when it's actually down here. I'll move over. All right. Sorry. Okay, so this is a moving average graph. You don't really need to understand it except to look at the direction that the little graph goes from left to right. We peaked, the deaths peaked actually in 2010. And while there was initial progress through 2012, something happened. We're not entirely sure what it was, but rates climbed up again. And but since the end of 2014, beginning of 2015, we've seen death rates decrease significantly. Right now, the overall rate is 5. Remember when I said that Modoc County was, let's see, where is it? Modoc County is 24 deaths per 100,000 population. Overall, the state is 5. So that tells you a little bit of the magnitude of the issue going on there. So right now we're back up around 2,000 with a rate of 5. But since 2015, we've seen a decrease. That's that drop off there. And we're hoping that this is sustainable. So why is this going down? Why are these death rates going down? Well, for one thing, we really are making progress on safe prescribing, and that's what we call it. This is interventions with physicians to make sure that if they are prescribing opioids, they're prescribing them in a way that is safe for people. Prescribing is down, so the sheer number of prescriptions are down. In 2010, there were about 23 million, and in 2017, there were less than 2 million, or right about 21 million. But also, the amount of drug, so the morphine milli equivalence, is down, and that's also very good. So that may mean that people are getting opioids for an acute issue, but they're really only getting 5 days instead of 30 days. So in both cases, they're down, and that's really good. But most importantly, the deaths have also come down. The overdose deaths are down. And that's really what we want to see, because it's all fine and good if prescribing goes down, if deaths don't as well. And so deaths have gone down from about 4.5 per 100,000 statewide to 3.3 per 100,000 statewide. And that's really good, and that was in 2012. It's been stable since that time. Okay, however, this is a very dynamic epidemic, sorry. How many of you heard about what happened in Indiana? It was sort of the thing that broke the news, right? So there was a very small county, not a lot of services, in fact, no substance use services, fairly poor, rural, and there were, as with our poor and rural counties, a lot of opioid prescribing going on. They locked down on opioids, prescription opioids, as we are all doing, but with some actually much more aggressive than we have been doing. And so all those people who were addicted to opioids with no services available to them switched over to heroin, which is a fraction of the price, and started injecting heroin. And because there were no harm reduction programs anywhere in the state, no syringe exchange programs, they also started sharing hepatitis C, hepatitis B, and HIV. So they had an enormous HIV outbreak, and that has changed the dynamic there. They actually have a syringe exchange program in a very conservative state, which has helped a lot with further transmission. But now they're in a situation where not only did they not have much in the way of services for opioids, or for substance use rather, they also didn't have services for HIV. So now we have a large group of people with HIV and no services available. So in California, our shift to increase in the rate of deaths has actually been a little bit slower, but we are seeing more heroin overdose rates. Right now, slightly under 1 per 100,000 population. And there were, I think, 594 deaths in 2017. But the real game changer here is fentanyl. Fentanyl is incredibly dangerous. This is a drug that, unlike most other drugs of abuse, kills you very early in your addiction. And if you're dead, you're not going to recover. You're also not going to cost the healthcare system anything. So there's this weird dynamic among people who have to fund services where not the people who, like us, who get it, but some other people who just look at numbers about, well, they're dead. Yes, and the point is they're dead, and we don't want them to be dead, so actually we really need to do something about this. The rate of fentanyl associated deaths has increased almost 300% in 3 years. That's unacceptable. We have looked at the first quarter data from 2018 of deaths, and it looks like it's increasing again. So this is a huge and urgent issue. So what are we doing overall in the state of California about the opioid epidemic? We have a very robust, multi-sector, multi-pronged approach with 7 key strategies that we hope, because they're comprehensive and because it's collaborative, will actually move the needle. We've already seen it start to happen in some areas, but these are the seven strategic areas. So we have a very robust opioid working group, which I'll tell you a little bit more about. We are working hard to promote safe prescribing policies and practices, which I think is actually turning the tide a little bit on prescribing at any rate. We are working to build capacity at the local level, where it's critical. I'll talk a little more about this, that change has to happen at the local level, not just at the state level. Promoting expansion of medically assisted treatment, which is the evidence-based practice for opioid addiction. Supporting more naloxone availability so that people don't die if they do overdose. Lots of public education campaigns going on because consumers don't know. We did some focus group testing around the state and realized that it's all well and good to tell people be careful about opioids. They don't know which of the drugs they're taking. My mother did not know that Norco, the drug that she was given after her shoulder surgery, was an opioid. And so that is a huge problem if we want people to take responsibility and be informed and aware. And then most importantly, everything that we do is based in data, and we monitor the data on an ongoing basis to see if it's working, to try to understand where the issues are and who is being affected and what the protective factors are. And that is the traditional public health approach. You've all, I think, probably by now heard about the collective impact approach ad nauseum, but basically that just means a lot of people from different sectors coming together with a shared agenda and mutually reinforcing strategies and approaches. The fact that we have this statewide working group that includes many different state agencies really paid off when it came to, and continues to pay off when it came to getting funding to address the opioids, because every single entity that is involved in the process has been able to leverage that partnership in grant applications to bring in substantial amounts of money from the federal government, including some really sort of semi-mind-boggling numbers. But since the really big numbers are going to be going toward treatment and direct services, they're always really huge. But let me then move on and talk a little bit more about what we're doing. So first is that statewide working group, which is now called the Statewide Opioid Safety Working Group. And it includes a lot of different partners. Started in really 2014 when the Association of State and Territorial Health Officers put out a charge to all state health officers to take on this issue of opioid. That increase that I showed you that started coming up in 2012 was what really put a spotlight on opioids. And so my predecessor, Dr. Chapman, actually brought together the state agencies. DHCS was obviously the first partner at the table, but also the medical board, the pharmacy board, and a number of other OSHPD, for those of you who know state language, Statewide Health Planning and Development, all came together to align messaging, to share information, so that to try to break down those silos that keep us from really being effective. In 2015, when I came, the working group was already well established, and we decided to open it up to external partners as well. There are currently 22 organization or agency partners in the working group, and over 40 state and non-state partners involved in 5 separate task forces that are addressing various issues with respect to the work that we're doing. I couldn't fit all 22 logos on the slide. These are just some of the key players in the opioid working group. The 5 task forces are working on specific areas within the overall approach to opioids. The integrated healthcare and policy is one that's literally looking specifically at the role of the healthcare industry, but and how we approach them as a system, as well as making policy to help restrict, and I'll talk a little bit about policy in a minute. The treatment working group working very hard in expansion of MAT and other services related to treating opioid substance use. Communication and outreach, a vital part of what we're doing. If people don't know there's a problem or don't know what to do about it, it's really hard to engage them in the process. Data gathering and sharing, and then our newest group, the Maternal Opioid Treatment and Neonatal Abstinence Syndrome Working Group. There's a real recognition of just how big a problem neonatal abstinence syndrome is now, and it's growing. And so we really want to figure out how we approach that specific piece of the issue. The work group itself coordinates all of that, but also works on policy approaches to addressing the epidemic. So I'm going to walk through those 7 strategies just really briefly. That was the work group. In terms of safe prescribing practices, that's actually where the bulk of our work has been done, other than public education. And as I said, I think it shows that it's working. From the very beginning in 2014, the Medical Board of California put out treatment guidelines, and while they may not be perfect, they were some of the first out there on the street well before the CDC guidelines. Right now we promote both because they're complementary and they really don't conflict. We have also been pushing along not only for the policy that mandated the use of the prescription drug monitoring program called CURES here, which is confusing for those of you who do federal work, because the CURES Act is related but entirely different. So when I talk about CURES, I'm going to be talking about the PDMP. It's run by the Department of Justice, a different partner who's been at the table since the very beginning. So we've been providing both support funding, but also then encouraging physicians to use it. Now they have to, starting in October, which is going to be a massive shift and very noisy. And then a lot of provider education, really, really important to do. We pushed out a lot of resources, the usual thing that we do, health alerts, et cetera, talks to provider groups. But the thing that we're focused on now, because it's demonstrated to work, is academic detailing. Anybody out there know what academic detailing is? You know when you go to your doctor's office or you're sitting in the waiting room in the hospital, the incredibly well-dressed people with nice briefcases walk by? Those are drug company representatives. And the reason they're there is to go into doctor's offices and talk to them about what drugs to use. And that's not all bad. It's gotten a bad rap specifically because of opioids. But academic detailing, meeting with physicians, meeting with prescribers one-on-one and providing detailed information is an incredibly powerful tool. So what the work group has done with partners, including UCSF, is create a curriculum around how to prescribe safely, use data to identify where the poor prescribing practices are most acute, and then working with local coalitions to train academic detailers to go in and have those conversations one-on-one with those doctors. And we keep very good data about change in prescribing practice after the academic detailing so that we know this is working. And so we're going to be ramping that up with some of the new money that's coming in. There's also a curriculum that was developed for pharmacists that has the same goal. We want pharmacists not only both to use and dispense naloxone, but we also want them to really know how to talk to patients about opioids and how to really give good information and actually just make them aware of the fact that this drug is an opioid. So the other thing is we recognize, particularly in primary care, one of the biggest issues has been primary care doctors. I can't tell you how many times I've run into this, say, I inherited these patients. And they did often. These are people who are on sky-high doses of opioids and have been for years. Now you take them over and suddenly you're going to say, well, you can't have that anymore. You can imagine. And also, who here thinks that we have enough treatment for substance use disorders in California? Right? So you're not only, and in the areas hardest hit, we have limited access to primary care at all and almost no access to substance use. There are people out there working incredibly hard in every single county, but they are not enough. And so now we have a physician who, A, never got any training in medical school, and I'll vouch for that, about opioids. B, if they're even younger than me, and I'm pretty old, have a mandatory requirement for education around appropriate pain management, which is all focused on don't undertreat pain, okay? That's another contributing factor. Don't make your patients be in pain. And now they're confronted with people who are addicted and are desperate for their medication, because that's what it is to them, a medication. It's a medication that helps them feel better. And many of those people have, or had at one time, legitimate reasons for those drugs. So making sure that we give providers useful resources on how to do what we're asking them to do, and then make the point to them is that it's not okay to just say, I'm not going to see you anymore because I can't get you off your drugs. Don't fire your patients, basically. I thought I was going to get in so much trouble when I put that in this, but actually it was okay. People were a little worried. But this document actually has a huge list of links, and it comes out in an electronic form that you can click on as a clinician and get lots of extra resources. And also expanding the medically assisted treatment, which is going to be happening even faster in the hub and spoke model with new resources, is going to really make a huge difference. This is what the opioid stewardship curriculum looks like. This is what we use for that academic detailing. It's got a lot of really useful information in it, and it's useful for physicians who are all ready to co-prescribe, who are ready, so prescribing naloxone along with opioids, but also want to get X-waivered. It includes information for those folks as well. So the work group itself has also looked very hard at policy. This past year, and really evidence-based or evidence-informed policies, not just any policy, because if you look across the United States, there are 4 million different policies, some of which there's not a lot of data that they work. Things like restricting the amount, by law, restricting the amount of opioid you can give somebody in a prescription. There's actually, that's a very common policy that's been adopted. It's not clear that it actually does any good. We've not adopted that policy in California, despite the fact that pretty much every legislative session, at least 2 bills wanting us to do that have come up. And what we're doing is using data to make the case that we don't need to do that here. We're already gaining ground, and we have other approaches. So that's what I mean when I say evidence-informed policies. So the goal of the main things in this policy, they're divided up into preventing unnecessary new opioid starts. So policies that do things like make sure that physicians get educated about opioids and about other alternative treatments. Policies that say to health plans things like, you have to also cover non-pharmaceutical treatments for things like low back pain, et cetera. So those are state-level policy changes that we can make that we know actually make a difference. Issues around managing pain safely, alternatives to opioids for pain. Turns out opioids really just aren't that good for pain, right? They really are not great drugs. They work great for acute pain in short bursts, but over time they actually make pain worse. And this is a phenomenon that a lot of people just don't believe, but it's absolutely true, and I've seen it myself. It's because of the way the brain works, and I'm not going to give you a neurobiology lesson, although it's absolutely fascinating. I do encourage you to read about it if you're interested. But also then policies around treating opioid addiction that have to do with making sure that, opioid addiction, all forms of medically assisted treatment are included under health insurance, things like that. And then stopping deaths. And in terms of stopping deaths, it's things like making sure that pharmacists can dispense naloxone without a prescription, which is one of the policies that we helped support. The goal of the policy framework, the thing that you're looking at on the screen right now, really is to have, it's sort of a menu of policy options. Every single legislative session since we started talking about opioids, and in particular since 2015, has had anywhere from 10 to 35 opioid bills. We needed to say to well-meaning legislators who really want to have their name on a bill and or know somebody who has died or is affected by opioids, there are good policies to adopt. And there are a lot of policies. We don't ever say bad policy, but we do say there are a lot of policies that we don't know work. So it's a negotiation in respecting all the restrictions that we have on talking to elected officials. That's my caveat. So anyway, the goal is to to make public a wide variety of policies that can be chosen from. Now, some of the things that have happened, the changes to Medi-Cal that Department of Healthcare Services made demonstrate just how powerful a policy change can be. Removing the TAR requirement, buprenorphine, within 6 months to a year, increased the number of prescriptions of buprenorphine by 51%. That's phenomenal, and that was something that they did. It didn't require going through a massive, process. They recognized it as important. There's evidence from around the country that it works, and they did it. And there were some other examples of things that have occurred on there. Another one that we think is really important that isn't actually being used as much as it should be was changing the law to allow pharmacists to dispense naloxone without a prescription. We are actually right now making a big push to pharmacists to please keep naloxone on in your dispensary. I don't think they like to be called that. At any rate, since it has a whole new meaning in the world of cannabis. But so in your pharmacy, keep naloxone stocked. Take the 1 frigging hour online training on how to dispense it and how to talk to people about it, and do it. And so slowly it was interesting when we wrote the statewide order that allows organizations that have access to naloxone to dispense it under my order rather than requiring another physician's prescription. The first 30 people who applied were pharmacists. So we kind of picked up the phone and said, hey, you can already do this. And so it's a matter of getting that information out there and getting them to understand that there really is a need in their community. One of the most exciting partnerships that we've had is with a group called Smart Care California. Smart Care California brings together the major healthcare purchasers in California. So we've got, as you can see there, let's see, I don't actually have the complete list, but between them, they cover 16 million Californians. So that's 40% of the people in the state of California have their health insurance through these organizations. That includes Medi-Cal, CalPERS, which many of you in this room have, or will have when you retire, but many state and local employees who are retired have CalPERS insurance, Covered California, et cetera. And I think a couple of the nonprofits are also under here. But basically they got together initially to address high-cost drugs. So things like some of the cancer drugs and some of the new drugs for chronic diseases. But in 2015, the California Healthcare Foundation, who supports Smart Care, along with DHCS, went to Smart Care and said, we have this opioid crisis, and we need your help. And then the next month, the CDPH came and showed some of the data and also talked about evidence-based practices for health plans. And Smart Care, what they did was they adopted a checklist of policies that every health plan should have to prevent opioid misuse. So what they did basically, they had 2 main priorities. One was managing low back pain. The other was preventing unnecessary C-sections. Both of those are things that they have very bad health outcomes, but they also cost a lot of money, and they're health insurers. So how do we do this? They added the opioids to their top 3. And the checklist that they had, these are all, again, evidence-informed interventions for health plans, policies for health plans, and they did a detailed literature review, case studies, interviews, and surveys of all California health plans before they came up with this. This is not a willy-nilly list, and it's very practical. And you can see up there things like these are the priority areas, and we're happy to share it's probably on the Smart Care website, but if you're interested in what those policies are. We just shared them with the Department of Managed Health Care as well, which oversees all of the managed care plans in California. But as important and impactful as everything I've talked about, these statewide efforts are, we're not going to save this issue if we don't work at the local level, because it really is in communities, I'm going to hurry up here, that we need to be working. And so one of the first things that the work group did when we expanded was to recognize that we needed the same kind of multi-sector collaboratives working at the local level. And California Healthcare Foundation initially funded some of these opioid safety coalitions, and now we've switched over since CDPH got some funding, so we're supporting 15 coalitions that cover 19 counties. In fact, you can see that the majority of counties in the state of California have opioid safety coalitions. These have been incredibly important, and they do things like academic detailing, but they also do tremendous work on combating stigma and bringing together law enforcement and substance use professionals along with public health and the healthcare system and the community as a whole to talk about a comprehensive approach to this issue. And so, and recently with some new funding, we've gotten some VISTA volunteers who are embedded in these coalitions to really, especially the small ones, need some staff to keep it going. It's very exciting. They're doing amazing work, and we need to keep pushing. There is also now a very exciting learning collaborative that's being funded by California Healthcare Foundation to make sure that they all share their information and understand. If you are working at the local level and you're not involved in your local coalition, how many people out there are involved? Outstanding. So look around. Talk to those folks. If you're not already involved and you work at the local, or even if you just care about this issue and you live in a local area, I think we all live in a local area, I'm just guessing. Sometimes I feel like I don't live anywhere, but because I'm moving so much, but please get involved. And then finally, and I promise I know I'm a little bit over time, expanding medically assisted treatment. This is critical. I know there has been historically an issue in the world of substance use. Abstinence is the only way to go versus medically. What we know for a fact, because it's been studied over and over and over again, with opioids, people who are addicted to opioids, you are vastly more successful getting people off opioids with medically assisted therapy because of the changes in the brain and because it is a different, the way the drug is used. And we're not talking heroin here necessarily, although it is also true for heroin. So opioids are a different issue, and we really do need a robust network of MAT, and DHCS is doing amazing work at creating the hub and spoke model. And then finally, we would really love it if nobody else died of an overdose that we can't prevent. And so getting more naloxone out there, we're doing that both through our naloxone distribution program, but also our Office of AIDS. They also do harm reduction. I think most of you are probably familiar with that. And so I'm going to just stop there. Let me go. There's some slides that you're welcome to have. Most importantly, though, I want to say thank you for the work that you're doing. I want to thank the incredible people at Department of Healthcare Services who are doing work on this, but also my team. We're sitting right there in our Safe and Active Communities branch. A lot of people together working on this. So thank you so much for the work that you do every single day for Californians. Do you want me to go down or stay here?
Isn't she fantastic? We're really, really fortunate to have great leaders like Dr. Smith carrying the message forward. And as she speaks a lot in California on the opioid epidemic, but she's also rallying the halls of the legislature and doing some extremely tough work behind the scenes. And we really just want to applaud her efforts and thank her for all the work that she's done on this issue. All right, next up we have Tyler Sadwith, and he is in charge of CMS's Innovation Accelerator Program. And I have had the pleasure of working with Tyler with the Drug Medi-Cal Organized Delivery System waiver. And Tyler and I have been at the start. We used to talk every day. I miss that kind of, except he'd always have like 5 million questions. How are you going to do this? I was like, I don't know yet. But what's really fun is Tyler coordinates all other states that are working on 1115 waivers for SUD. And so I got to go to a convening about 2 years ago, and I was so excited. Tyler had brought together the states, and I was ready to go talk to him. And it was sort of like when you're at a park and somebody has like a bag of bread, and all the pigeons, they're kind of like just milling about until that first little breadcrumb goes out, and then they're like, whoosh. Well, that was it. I was like, oh, there's Tyler. And then all of a sudden people were like, Tyler! And there was like, whoosh, right on the breadcrumbs. So I was like, no, I guess it's just not California. It's helping other states. Well, that's good. I mean, it's great. And so he is really, and I'm embarrassing him right now, I can tell, but he truly is one of the leading national experts with substance use disorders. And we have been so fortunate that he really came alongside us and really helped craft our waiver, and really, along with John O'Brien, carried it forward over to Washington. And so we would never have our 1115 waiver without Tyler. And with no further ado, I'd like to welcome to the stage.
Hello, good morning, everyone. And thank you, Marlise, for those kind words. There are good things about the DMC ODS. They come from Marlise and the counties, and if there's anything wrong with it, you can blame it on me and CMS. I'd like to thank Dr. Smith for her remarks. It was a really insightful framing of the opioid problem in California and the public health response. I think there's obviously a lot of robust and compelling work being done, and I think you'll hear a lot of similar themes in key areas of focus in some of what I'll talk about. So this morning I have the opportunity to communicate and share the federal perspective and updates on some of the work and activities and programs directed in response to the opioid crisis in the United States. Within the Department of Health and Human Services, a 5-point opioid strategy was outlined in April 2017, which provides the overarching framework to leverage the experience and the resources of HHS strategies to really address the crisis in a strategic and coordinated manner. So the HHS opioid strategy aims to improve access to treatment, recovery, and prevention services. It aims to target the availability and the distribution of overdose reversing medications. It aims to strengthen public health data reporting and collection to improve the specificity and the timeliness of the data. It aims to support cutting-edge research so we can better understand pain and addiction and lead to the development of new treatments. And it aims to advance the practice of pain management to enable access to evidence-based care for pain while reducing inappropriate opioid use and opioid-related harms. So the department has taken significant steps to advance these goals, including work being undertaken by HHS agencies like the Food and Drug Administration, the Centers for Disease Control and Prevention, the National Institutes of Health, the Administration for Families and Children, and the Substance Abuse and Mental Health Services Administration, among others. Given my perch within CMS, I'll focus on efforts underway within my agency, especially within the Center for Medicaid and CHIP Services, which oversees the Medicaid program. So within Medicaid, we're undertaking a number of strategies to strengthen existing programs, to develop new policies, and to provide states with opportunities to accelerate their ongoing efforts to address the opioid crisis. We continue to issue guidance to states to provide information on effective state initiatives and options and strategies available to states in Medicaid. So in partnership with SAMHSA and the CDC and the National Institute on Drug Abuse, CMS issued a bulletin highlighting the potential for states to implement medication-assisted treatment. Prior to the CDC issuing their opioid prescribing guidelines for chronic pain, CMS issued a bulletin describing pharmacy benefit management techniques and ways that states can manage the prescribing of opioids and ensure appropriate use and reduce misuse and abuse. CMS followed up with a bulletin highlighting flexibilities states have to ensure the availability of naloxone in their community. Options to allow pharmacists to dispense naloxone, like some of the work that Dr. Smith did here in California. This year, we issued a bulletin on neonatal abstinence syndrome. The bulletin provides states with considerations for coverage approaches and benefit designs with regards to treatment of infants with neonatal abstinence syndrome, or NAS for short. We also issued guidance to states that identifies and describes federal funding authorities and opportunities related to health information technology efforts, so states can leverage federal funding to improve their prescription drug monitoring programs, which are key tools for ensuring appropriate utilization of controlled substances. And of course, CMS is leveraging its authority under Section 1115 of the Social Security Act to provide states with flexibility to design and test demonstration projects in Medicaid, including pilots pertaining to substance use disorder. 3 years ago, CMS offered a new opportunity under 1115 authority to allow states to cover the full continuum of addiction treatment, including residential services, which otherwise were not covered by Medicaid in settings with over 16 beds due to the IMD exclusion. And as I'm sure many of you know, California was the first state approved under that policy. Several other states followed California's lead, including Massachusetts, Maryland, West Virginia, and Virginia. Last year, CMS issued new guidance to modify the SUD waiver opportunity. So the new approach streamlines sort of the previous criteria, but it also increases states' responsibilities to monitor and report and evaluate the impact of these demonstrations. Many of the programmatic requirements that were in place for California are in place today with regards to service coverage for critical levels of care, using SUD-specific evidence-based patient assessment and placement tools, using national standards for residential providers. So, the core mission to support states to cover the full array of services within the context of delivery system transformation remains. So these are really milestones that states are committing to meet over the course of their waiver. And when states apply, we ask them to develop implementation plans to describe the steps and the timeframes they need to meet those milestones. CMS collaborated with states and with a contractor to develop a set of metrics that states will report. So states will submit a monitoring plan to report these measures and other data that are specific to each state to track performance on their demonstration and progress on achieving those milestones. So that's the update on the waiver, and I just want to take a second to highlight how important the 1115 SUD waiver option is to CMS under this administration. CMS and HHS officials have testified to Congress about the agency's strategies to address the opioid crisis, and the SUD waiver is the core initiative that they highlight with respect to CMS's strategies to improve treatment in Medicaid. So I mentioned 5 states, including California, that were approved under the original guidance in 2015, and just to give you a sense of how this work has paved the way for other states, I'd like to list the states that have been approved under the new guidance. Illinois, Indiana, Kentucky, Louisiana, New Hampshire, New Jersey, Pennsylvania, Utah, Vermont, and Washington. States that have submitted proposals that are currently pending: Alaska, Arizona, Kansas, Michigan, Minnesota, North Carolina, New Mexico, Tennessee, and Wisconsin. So I'd like to take a second and recognize the fact that none of these states would be expanding coverage and improving access for their beneficiaries without California. There would be no 1115 SUD waiver opportunity without California. So everyone in this room, from DHCS leadership and staff to the county teams that are reshaping systems of care, to all the providers in the room who deliver care every day and adapt to new changes, to tribal partners and other service providers and advocates, everyone here has played a role and contributes to improving care not only for Medi-Cal patients, but for millions of Medicaid beneficiaries across the entire country. And I'd just like to thank you for that. Let's do a round of applause for you guys. So now I'd like to touch upon my favorite topic, which is the Medicaid Innovation Accelerator Program, or the IAP for short. The IAP is a technical assistance delivery platform that's designed to support states' ongoing delivery system reform efforts. And I've had the good fortune of working with states through IAP to provide technical support on their policy, payment, and program reforms related to substance use disorder. IAP has offered over 30 national webinars and engaged 50 states on topics like value-based purchasing approaches for substance use disorder and strategies for hospital emergency departments to initiate medication-assisted treatment and facilitate referrals directly into treatment. And that's some of the work that Dr. Herring will describe. IAP has developed tools and made them available on Medicaid.gov. These include an overview of the ASAM levels of care and tools that describe episodes of care and bundled payments for MAT that can serve as a starting point for considerations. We continue to provide technical support to states pursuing the SUD waiver. Our overall approach is to support states and to provide momentum and to convene states together in ways that are useful. And this year we're offering a few opportunities targeted to opioids. For states that are in their early stages of examining their data, we launched an opioid data analytics cohort, which really is designed to support states to size and stratify their opioid problem so they have a richer set of data to inform their planning. So the opioid data analytics cohort is comprised of 3 components. The first component is about sizing the magnitude of the opioid epidemic in Medicaid. So we're supporting states to get a better sense of the characteristics of the opioid population by demography, by age and gender, eligibility category, delivery system, and we're helping to break down some of the medical and behavioral and pharmacy expenditures and service use to see what kinds of medical services people are accessing and if people are getting treatment or not. The second component in the analytics cohort is focused on the availability and distribution of medication-assisted treatment, or MAT. So we're providing each state with a list of prescribers that have received the Data 2000 waiver to prescribe buprenorphine. And we're helping states merge that data with Medicaid claims data so states can see who in my state has the waiver to prescribe. Are they participating in Medicaid? Are they actively prescribing to beneficiaries? Are they prescribing at full capacity? And we're helping states look at some of the characteristics of MAT as well. Are people receiving MAT diagnosed with SUD? Do they have a diagnosis for OUD? Are they receiving toxicology screens? Are they filling prescriptions for benzodiazepines or opioids? What's the impact of MAT? What are the readmission rates for hospitals? What does follow-up after the emergency department look like for that population? And we're also supporting states to examine, as part of the last component, really helping them look at maternal care and pregnant women with opioid use disorder and neonatal abstinence syndrome, doing some of the stratifications on demography, eligibility, delivery system, and looking at, what are the costs associated with treatment, with prenatal care, with pregnancy, with delivery, and for neonatal abstinence syndrome, what does treatment look like? Are medications being used? Are there stays in the NICU? How long are the stays? What are the total inpatient costs? And for all this data analysis, our real emphasis is on the so what. Right? So our goal is to partner with states to help them assess and interpret the results and to provide strategic considerations around some of the planning and the policy options that they can consider based on the data that they're finding. So states that participate in the opioid data analytics cohort include Colorado, Delaware, Indiana, Kansas, Kentucky, Maryland, Michigan, Missouri, New Hampshire, New Jersey, South Carolina, West Virginia, and of course, California. And IAP is also supporting another group of states through the Opioid Data Dashboards Flash Track. That's really geared for states that are interested in developing dashboards to display their opioids data and performance, so they can do some of what Dr. Smith and her public health colleagues in other states do. It's really about monitoring and displaying key performance indicators for a target audience. In this case, it could be public constituents, it could be key partners like managed care plans, or it even could be internal leadership. And through the Opioid Data Dashboards Flash Track, we are working with Florida, Oklahoma, Tennessee, Virginia, Washington, D.C., and West Virginia. The last item that I'll touch upon with regards to how CMS is addressing the opioid crisis within Medicaid is just to highlight the Medicaid health home option. So health homes are an optional benefit introduced by the Affordable Care Act that allows states to receive enhanced funding for care coordination and care management for individuals with chronic conditions. And this specifically includes substance use disorders, to include opioid use disorder as well. So several states have implemented a health home benefit targeting opioids, including Maine, Maryland, Rhode Island, and Vermont. And Michigan has also submitted a proposal that is pending. And just to provide an example, Rhode Island leveraged their opioid treatment program providers to serve as a basis for their opioid health home. So beneficiaries who meet the criteria to receive MAT are auto-assigned to an opioid treatment program health home with the option to opt out if they want. Patients are admitted to an OTP, and within 6 months, the goal is to transfer them to office-based opioid treatment for maintenance so they can access providers in the community. And Rhode Island designed an enhanced option for their OTPs to become certified centers of excellence. So centers of excellence are OTP providers that have enhanced administrative and clinical capacity, enhanced staffing patterns, and are eligible to receive additional payments for that. And I'm sure many of you are familiar with Vermont's opioid health home called the hub and spoke system. Vermont has achieved solid results from hub and spoke, including a decrease in overdose deaths, a decrease in emergency department visits and inpatient admissions, as well as showing cost savings for Medicaid. And now hub and spoke is becoming available in communities across California. And I hope that it allows people to enter into recovery and to reclaim their lives. And so this brings me to my closing remarks, which is, I think, to touch upon some of the themes that Dr. Smith alluded to with regards to sort of cross-sector collaboration. Simply put, there's no one agency or one part of our healthcare system that will mitigate the opioid epidemic alone. So a core principle is really collaboration across stakeholders. It might mean forming new partnerships. It might mean developing new relationships. This is happening in government. A state shared with me recently that through a perinatal learning collaborative dedicated to addressing NAS, there was a case conference for a mother who had given birth to a baby with NAS. That involved 17 different agencies coordinating to achieve the best outcome for the mother and her infant. And so that's a lot, but it's emblematic of what it means to partner across systems and to overcome silos to confront this epidemic. This is happening at the level of service providers. Dr. Herring and other emergency department physicians are treating patients with opioid use disorder just like patients that appear with strokes or heart attacks, initiating care based on evidence-based guidelines, observing or admitting patients, and referring patients to specialty providers at the right level of care based on their acuity. I believe that his work in the ED Bridge program will increase engagement in treatment. It'll increase initiation in treatment and retention in treatment, and it will reduce overdoses, which are the leading cause of deaths for Americans under 50. It's why the work of Marlise Perez to launch the hub and spoke system, it will significantly increase specialty and primary care treatment capacity, especially in underserved areas. So that's cross-sector, cross-system collaboration that's going to make a tangible difference, and it's going to make an impact in the lives of patients and in the lives of their families as well. And so, when Marlise partners with tribal leadership and tribal representatives and stakeholders to design the tribal MAT project, there will be more funding, more supports, and more culturally appropriate services available to American Indian and Alaska Native communities in California. So these are new collaborations, these are new relationships, these are new joint ventures that are emerging out of a common resolve to address the epidemic. One of the authors or contributors to the ASAM criteria, George Kolodner, shared an anecdote about meeting with a patient after intake. So the patient was sitting in his office, he was feeling raw, tired, not particularly motivated. And Dr. Kolodner said something to the effect of, "You need to go to group right now." You need to connect with your peers. That's where treatment happens. That's what the treatment is. And that's how I try to approach my work at CMS and in the Innovation Accelerator program. So it's not the official federal perspective, but this is my perspective. CMS can regulate and fund states and provide opportunities, and IAP can facilitate connections and serve as a catalyst. But sometimes we just need to get out of the way when it makes sense. We just need to help peers connect with each other to learn about what's working and what's not working, and what are some of the effective and emerging approaches to addressing the opioid crisis at the program level, at the policy level, and at the practice level. So that's why it's an honor to come to this conference and learn about the bridge building that's occurring here in California with respect to SUD and opioids. And it's great to hear about the solutions that are being developed at the local level to address this dynamic and this rapidly evolving epidemic. Thank you.
I get to work with these people. Isn't that awesome? Great. So our final speaker for this morning is Dr. Andrew Herring. And I'm just going to read his bio because I keep messing everybody's up. And I don't want to mess yours up, Dr. Herring. He's right over there. Dr. Herring is an attending emergency physician and attending physician at Pain and Functional Restoration Clinic at Highland Hospital. He's also the director of the ED Bridge program, and he's going to talk a little bit about what ED Bridge does. But it basically integrates the emergency department and also with clinics and substance use disorder providers in the community. And as he comes on up, if you haven't seen it this last weekend, there was an incredible article about the work that Dr. Herring and his team is doing in the New York Times. So please go back and look at that because it was just absolutely phenomenal. So I would like to welcome Dr. Andrew Herring.
Hello, everyone. Thank you so much, Marlise and Tyler. It is a super thrill to be here. This is a very exciting time for all of us. I think that clearly, we're facing a really, really horrible epidemic with lives shattered, lives lost. It's a very dark time, but it's also a time where many of us in this room, for the first time in our careers, will have funds to really try to do something about this. So I just couldn't be more grateful to be part of this group of people out there trying to make a difference. So, okay. I'm an ER doc. This is what I did not start in addiction medicine. I didn't start in pain medicine. I started out in the ER. I love the ER. The ER is an incredible place. It is where there's a clinical intensity there, where you really see what works, what doesn't work, what's happening in the community. There's no barriers. It walks in the door and you got to figure it out. We've been treating folks with opioid addiction at Highland for decades. This is nothing new, right? We've had heroin in Oakland for a long, long time. The standard approach, traditionally was supportive care, or look, sorry, you got to do what you got to do. We got to move on, right? Then what happened is we had the opioid epidemic comes, the decade of treating pain and the proliferation of OxyContin and Percocet and all these things. So suddenly the ED became this massive battleground for refills on prescriptions, requesting treatment for pain, Dilaudid, injectable morphine, all of this stuff. It became this daily grind of fighting with folks or capitulating and all back and forth. And then we sort of looked at the science and really saw, just as has been mentioned today, that the opioids are not that great for pain. There's a lot of fundamental problems with the pharmacology of opioids and pain. And we thought, okay, this is the way to approach this. We don't need to use opioids at the same level. We can reduce our prescribing, reduce our use, and that's how we're going to solve this problem. So I'll give you a case. Here in this exact hallway here, right around the corner, I met a gentleman in his 50s. He came at 4 o'clock in the morning, homeless, complaining of back pain. And he just wanted Norco. He didn't really want to talk to me about the details. He didn't want to engage. He was just like, I want Norco. So we were emboldened that, no, this is really, we know Norco doesn't work for long-term back pain, right? And you shouldn't be getting Norco prescriptions out of the ER. It was pretty clear, right? I examined him. He had a normal exam, and we gave him a sandwich, and he went on his way. Then he comes back 3 or 4 days later. The same thing happens. Normal exam, asks for Norco, doesn't get it, right? He comes back a week later, or actually 2 weeks later, and he's paralyzed, right? Right, his left leg doesn't work. The whole time he had an epidural abscess that was brewing there, right? And that was a moment, was like, this is just saying no, just creating these barriers prescribing, it's not enough, right? Our interaction, there was no engagement. He wasn't engaging with me, I wasn't engaging with him. We were in this dumb battle, right, over this pill, right? Where right in front of us, this sort of giant elephant in the room was he was struggling with addiction. He didn't want to actually tell me he was injecting drugs, right? And I was all hung up with telling him he wasn't going to have Norco and didn't go the extra mile to really find that out. And the outcome was horrible, right? So he's doing better, he's regained some function, but he's still in a wheelchair, right? That was my case. And there are thousands of those kind of cases out there. So, this was this big moment where, Gail D'Onofrio and the Yale team said, look, we can do things differently, right? We can introduce this idea of addiction treatment. We can train doctors to understand addiction and to deploy it into their practice like the emergency department. And she started recruiting patients out of the ER to start them on buprenorphine. And it worked, right? It was a no-brainer. Like the idea of giving someone a referral sheet versus actually also giving them evidence-based treatment with buprenorphine, it doubled their chances of retention and treatment. It was an obvious study that worked really well. So contrast that first case I mentioned with this gentleman. This is the very first person I ever treated with buprenorphine. This is Alex, right? And he's given me consent to use his photo. So his story, but he was a friend of a colleague that I was working with and knew that we were trying to get this little program off the ground and see what would happen, right? We were all scared. So he was on buprenorphine for some amount of time. And then after having heroin addiction, he had a knee operation and got started on full agonist opioids. And then the restrictive practices kicked in, right? And we all know what happens next. He went back to using heroin. He was freaked out about it and he wanted to get back into care. He didn't know where to go. So here he comes to the ER. And in this one interaction was just an absolute revelation because he was trusting me. I was saying, I'm going to help you, right? Here you go. I want to engage with you and learn about your life and figure out how to get you to the next stage. And he explained to me that for the previous years, coming to Highland and other hospitals, that when he was using heroin, as is very, very common, he wanted to get off, right? And so he would initiate self-directed, at home, going cold turkey, abstinence type stuff. You go into a moments of feeling in desperation and you're in withdrawal and you don't know what to do. It's 3 o'clock in the morning. If you call up your dealer, what's that, right? That's failure. That's going back to where you wanted to go for. So it's 3 o'clock in the morning. You just need a little opioid to get you over the last little bit of your trying to get clean. Right? Where do you turn to at that time? The ER. So he'd go to the ER. And if you walk into the emergency department and you say, hi, I have opioid addiction, I'm kicking really hard, and I'd like IV morphine, what do you think is going to happen? Right? So what were the, circa 2012, what's the magic word for opioid? Right, 10 out of 10 pain. And so he would go in and he'd say, I have 10 out of 10 pain. It's right down here. What's this down here? The appendix? Right? So the medical legal environments being what they are, the ER is compelled to do tests and CAT scans. He'll get some morphine, right, and he'll feel better. But what was his whole goal along here? Was it to score morphine? No, right? He was actually trying to get clean. So he knew that if he went back to his apartment with his girlfriend who was also using, he'd go back to using. So then what was the magic word to get entry into a protected residential facility? Anybody? I'm suicidal, right? And so he would say he was suicidal. He'd be placed on a 5150 and be sent to our locked facility, right? Now, who doesn't think that that's insane, right? It's a totally crazy idea. And that story, in some version of another, happens with an incredible frequency because of this stigmatized suppression of just treating this as a medical disease. So instead of doing that, we just gave a prescription in fast track, like sitting in a chair, right? So contrast all of that testing and expense and this duplicity and lack of trust with just a simple, clean relationship. So this was the genesis moment where we decided, okay, this really works. We need to do this, right? We need to scale this up. And so with the ED Bridge, we have a very simple but very ambitious goal. And it's that we want to provide 24/7, 7-day-a-week access to buprenorphine treatment in all counties in California. And the ER system is sitting there on the tarmac. It's this gigantic public health system that has been invested, billions have been invested into having hospitals that are open 24/7 with a high-powered clinical team ready to treat you. And all we want to do is get all of those ERs to stock buprenorphine in the Pyxis and use it. I don't need every ER doc in California to become an addiction specialist. I don't need every ER to become a center of addiction excellence. I just need them to buy into this simple message, is that when someone comes in with opioid withdrawal, needing treatment, that they can receive it right there on the spot, right? That's it. So from there, we're building resources on how to actually make this happen. Because once they do it, right, then that's where the rest of us need to come to the rescue, right? The ER has kind of done their work in a lot of ways, is that none of us who have our outpatient clinics or our programs, none of us are awake at 3 o'clock in the morning on Sunday treating patients, right? As to expand all of our services to do that is impossible. So we have to partner here. So the ER is going to create this huge contribution of providing this kind of real-time access. But then we got to do our part and be able to take the baton, right, in a way that's clean, without a lot of restrictions, without 2-hour intakes, without all these eligibility requirements. We just got to take them in and run with it. So that's the second piece that I'm really looking forward to seeing what we can develop as a community in terms of this low threshold access to buprenorphine after we've got people started. So part of the sort of fun things that we're kind of working on to try to make this work, because we got to think about an ER doc who doesn't have a lot of experience. They just know that the buprenorphine is in their Pyxis. We're working with the California Poison Control to create a 24/7 hotline so that any doc who's in front of someone, like one of these folks I've talked about, who's in withdrawal, can pick up the phone and be like, what do I do? Wait, is the DEA going to come get me? Right? I can just give it to him? Right? All these simple stuff, right? And how much do I give? All these basic questions. So that's the poison control line. I think this is a wonderful use of their services. So we're really hoping to see that expand. Now, the basic model, again, is that if you actually don't have withdrawal, right, this is someone who can probably go somewhere else. When we talk about expense and appropriate care in appropriate places, this kind of thing. There are lots of places you can, that we can think of to be a walk-in center for someone who's not in withdrawal. But when you are in withdrawal, my message is that is an actual medical emergency. Because when people are in that state of wanting to quit and they're in withdrawal, right, or there's other circumstances push them in withdrawal, they are at much, much higher risk of overdose. Someone who is stably using an opioid, right, in any given point in time might actually have a fairly low risk of overdose. But it's when there's crisis and they go into withdrawal that they use someone else's dope that they don't know what the source was. They use alone. You use alone and no amount of naloxone is going to save you. Right? Use in a different place, use different amounts. All these things happen. So withdrawal is a high-risk moment that we need to take seriously. And that's where you kind of run into this pathway here, where this is a medical emergency, and the treatment is buprenorphine. There are other options, but this is the one that really works. We know how to do it. It works really well. It's simple. The beauty of buprenorphine is it has a long half-life. So depending on how much you use, you can provide 24, 48, 72 hours even of suppression of withdrawal symptoms, suppression of craving, and importantly, opioid blockade. So if they go out and they use something else, they're not going to experience significant respiratory depression and overdose. So it's this life-saving little capsule, this little bubble that you can put over someone anytime or day or night. Okay, so screening. One of the things we really try to do is, we're not saying to people like, hey, do you have opiate use disorder? Would you like care? Would you like, a hand-in-hand to recovery? These kind of euphemistic things. We want to be really straight up, right? Just be like, look, we can give you buprenorphine. You've heard about it. You've heard about subs or whatever. Like, we can give that to you right now. It's a very pointed thing, and that is our screening. Because I like to think of it, if you walk into 7-Eleven, right, do they hand you a survey and ask you is your stomach grumbling? Are you noticing, saliva when you look at that hot dog? They offer you the hot dog, they say, here, go for it. So that's what we're saying. And we have these signs up at Highland where they're very straight. Like, do you need help with pain pills or heroin? We want to help you get off opioids and start it on Suboxone, period, right? And other folks are doing this. So who reads this? The patients read it, so does their sister, their mother, their brother, their sister. Other people see it, right, in the course of just regular care. So we've had these incredible cases of, the mom brings in their kid who has a URI and sees the sign and then comes back 2 weeks later because it turns out that she feels like she's addicted to Norco. Those kind of things. So this has been a real game changer for us. And where we're kind of going is this French experience, right? I'm not sure how much people know about this, but basically in France, they had a wave of HIV/AIDS that swept the country in the late 90s that freaked them out. There were a lot of good motives, bad motives here, but they were terrified that this was going to take over their society. So they unleashed buprenorphine in this totally disorganized, unregulated way, without training, without anything. They just basically had all the primary care docs, all the pharmacies to start using buprenorphine, right? And what happened? It worked, right? So that was the crazy thing, is that the lack of regulation, the lack of barriers and threshold turned out to be a hugely good idea. So right now, we're kind of over here, and France is over here, and we got to find somewhere in the middle. The Bakersfield is not Paris, I get it, right? So or San Francisco for that matter. We can't just take their model off the shelf. But clearly we do have to recognize that regulatory barriers do impede care, and right now we're kind of in this battle, right? The battle of the opioids, right? The opioids are out there, right? They are out there. There is a lot of access to opioids, and this graph in particular, as we've talked about today, some of these, fentanyl and its analogs in particular, are incredibly dangerous. So what we need to do is we need to be able to combat this access, right, of these other opioids with access to an opioid that we know is safe. Would I prefer and just wave my hands that basically none of these folks have ever been exposed to an opioid? Yes, but the cow is out of the barn, right? There is millions of people exposed, dependent, with use disorders on opioids. They're going to get an opioid. And the question is, are they going to get an incredibly safe one, or are they going to get an incredibly dangerous one? And that's why widespread access is basically the only thing that I can see which is really going to have a chance to work in terms of lowering a population scale risk. Other thing to think about is there's a dominant paradigm around this idea of kind of chaos, and then initiation, and then stabilization. But that's not really what happens, right? So this is what happens when you start on buprenorphine, and then how long you stay in treatment. And what you see basically is that there's this large number of people that get started, they try it out, and then they get off. right? They get off it too quickly. And then there's this distinct population, 30, 20% that stick to it long term. So what this means is that we have to be able to have this cycling set of second chances, right, for this group at the top. They try it, they give it a shot, they see how it goes, it doesn't work, they relapse, they get back on. And the quicker that wheel turns, the more people we get churning through that funnel, it's how we're going to produce these long-term engagements down here. So it makes very little sense to put barriers up at the top of this graph, right? Because that's how we're going to get people into the system. So again, low threshold access. So this is what we see in the ER, is basically we're giving people a chance to give this a shot, to get onto this treatment and see how it works. And if they fall off, we give them a chance to get back on right that day, right? With the idea that maybe it's the second time, the third time, the fourth time, the fifth time, that they're going to stick and engage, right? So, barriers. This is not completely simple, right, to make this actually happen. We've got a lot of barriers. Waivers. Are all ER doctors in California going to get waivered? No way, right? No way, not going to happen. And then the ones who are waivered, are they going to, you ask a doctor who maybe isn't, not in this room, but who basically say, hey, here's a person who is clearly addicted to opioids. You've never met them. You don't know anything about them. I want you to give them a prescription of opioid. Right? There's a lot of like, no way, man. I'm going to go take care of that heart attack. You got that one, right? I'm not doing it. It's just like it's a non-starter. So the other thing is this sort of tyranny of the handoff. I'm a board-certified addiction specialist. I treat, buprenorphine in longitudinal in my SUD clinic. I receive people that are transferred to me. I don't need a warm handoff, right? We cannot burden these portals with long intakes and, inventories of housing and this and that and this and all these things, which are incredibly important. Don't get me wrong, but they're not the sort of specific goal here, this focused goal of initiating treatment that gets in the way. So the big key thing is the ER can get people started, but we need partners who are willing to take that patient on without a whole lot of baggage, right? Because the reality is you can ask all those questions after you've continued the buprenorphine. Prioritizing, preventing any lapse in treatment. So, this is what I see. This is one of my patients at the pharmacy. It is so casual, so cavalier that we will deny people prescriptions. Little technicalities, their address, their ID, these little things, and it'll just, sorry, no meds. Now think about that from the patient's perspective, right? That just sends the message that we don't really care. We're going to send you into withdrawal because of some little thing and just talk to the glass window, right? We have to fix that, right? We cannot let lapses in treatment be so trivially just executed by any pharmacy or medical system without some kind of sense of scrutiny and oversight. Like, that can't happen. People who are started on buprenorphine have to be allowed to continue. This idea of medication first is important. This is, for us, if we don't have our blood pressure pill in the morning, no big deal. If you don't have your Suboxone in the morning, your buprenorphine in the morning, your methadone or whatever, it is a huge deal. And I just see systems don't take that seriously enough. We got to be creative. This is where I needed a place for my ER folks to follow up. Did I have like a gleaming, clinic ready for me to walk into? No way, right? We kind of got to build our own taco trucks, right? We just got to do this, So I found literally the farthest hallway and corner, possible in Oakland. I mean, at Highland. Literally, if the CEO's office is sort of up here, literally this is the farthest point, like down and away. It's like a building, built out of Adobe. It's like any earthquake comes, bye-bye, sorry. But it had a space, it had a space. It had a storage closet that we could clear, right? We could clear out the boxes. Thank God you can't see what that carpet really looks like, right? Because it looked like someone slaughtered a wildebeest there like 10 decades ago. It's really horrible. So, and I don't have a medical assistant, so we find a vitals thing. I do the vitals. We have medical students and volunteers to make it happen. It's just sort of scrappy, that attitude of just let's make this happen, right? Because fundamentally, if you don't take on the world, I'm not going to take on the HIV and Hep C and homelessness and PTSD and all of these other things that are going on. I'm just going to say, I'm going to take this little piece and I'm just going to make it happen, right? If you do that, you don't need a whole lot of resources. It's wonderful to have them, and go for it. Advocate, fight, get those resources for your patients, but don't let that be a barrier. Just get onto the field and start playing, because that's how we actually learn how to do this, right? Because each one of these folks has so many unique challenges that we can't ask one person to take them all on. So then, to conclude, I just have to say that if there's one, magic pill, if there's one thing that's going to make this work, it's engagement. It's prioritizing engagement. That letter that says, don't fire your patients, that's such an important message. What I see is that there are a lot of programs out there that have these chutes and ladders where it's so easy to get fired, to get cut off your contract. You didn't do this, you didn't do that, or whatever, and you're gone. And where are they going to go, right? The dealer down at the encampment, is he ever going to fire that patient? No, right? He's like, welcome on back, here you go. So this is something that we have to create a space that we can maintain engagement with patients who are easy and who are difficult, patients who are nice and compassionate and you form these great bonds with, and the ones that have antisocial personality disorders and blow up at the pharmacist, and aren't always so polite in these kind of things. And I think in the end, what we've all seen, is that this treatment works, right? It can take time, it can take multiple shots at it, but folks who you just never, if you saw them in the depths of withdrawal and addiction, you would just never dream in a million years, right, that they would look so good, right? But then lo and behold, weeks go by, months go by, and they do. And it's one of the most inspiring things I've ever seen. So thank you very much for your time.
Well, like Dr. Herring says, the cow is out of the barn. Love that. Great. Well, that concludes our morning session. But before you go, I did want to just have a small announcement as we are releasing some new projects under our California Medication-Assisted Treatment Expansion Project. We have received some additional funding, and we've just applied for some more. But we're going to be doing a statewide naloxone distribution project, similar to what public health has done, but they focused on the counties and the health. We're going to be focusing on non-health entities. So we're going to be releasing about $20 million over the next year. So for you folks, I want you to be the first to really hear about it. You can refer your sheriffs, law enforcement, homeless shelters, any of your needle exchanges, or groups that really need the naloxone. And so that will be rolling out. You'll be able to send your entities to the Department of Health Care Services website. They're going to be able to complete a very simple form of what their entity needs, how much naloxone. If they don't have a standing order, they'll be able and referred to Dr. Smith's her standing order so they can distribute it. So we're super excited about this partnership and collaboration. But to kick things off today, underneath 20 seats is an envelope, and you yourself can get your own naloxone kit. So as you're leaving out, just look under your seat and see if you have it. And then if you do, just complete it and then turn it in at the registration desk. Thank you so much, and we'll see you back here at lunch.